Good morning, and first of all, welcome to all of you for the first AIOC midterm. There is no nil financial interest, and we are in a contracted socket defines absence of functional eyeball from orbit. And what happens after a patient expectations about aesthetics after enophthalmia, what they understand, its ideal ocular prosthesis is a natural looking that friends and family don't know, but the medical point of view is eyelids should be at a normal position, ability to blink and eyelashes in normal position, symmetrical with healthy eye, and also as good motility custom processes. So a common scenario is whenever a patient comes to us, we give a radius stock artificial prosthesis in presence of adequate socket, which is called grade 0 socket, where we have a adequate 13 millimeter of superior fornix depth, 9 millimeter of proxy around the lower fornix, and grade 0 socket is also lined with a healthy conjunctiva, has deep and well formed services. So, but for Krisa et al. Has a 5 grades of management of contracted socket. Grade 1 is shallow lower fornix with the shelving of the lower fornix, while grade 2 is the loss of upper as well as lower fornices, and grade 3 is the loss of upper, lower, medial and lateral fornices, while grade 4 has a palpebral aperture narrowing as well in a horizontal and vertical dimensions, while the 5 is the repeated results after repeated reconstruction. So aim of construction is to establish stable furnaces by increasing the surface area or by increasing the size, and the ocular prosthesis should be light once provided latter to take its supports from infraorbital rim, not the lids. So the options are, if it is minimal defects, we can go with the Z-plasty and local conjunctival flap. Moderate contracture, it can be buccal mucosal graft, and volume loss, definitely dermis fat graft is required, and if there is severe contracture, we can go with the prosthesis, which is itself designed to be fit there. So prevention is with the use of conformer in the early childhood to allow the growth of the orbit, and if it is in a posterior period, it also helps to help the oculars increase the size of the conducted socket. My first case was a one-eyed 67 years old sannyasi presented with inability to use old prosthesis as it slips every time from socket and has lost many in due course way back in 2010. So you can see post surgery, it was conjunctival socket reconstruction was done using buccal mucosal graft in 2010, and he got a custom made prosthesis after alligate at different places after socket reconstruction. This is the second case when we can say it looks like a grade 4 socket, and the buccal mucosal graft was again taken. Conformer were used in an increasing size, and later on this socket become large enough to allow the radius stock custom prosthesis itself. So while we are doing the buccal mucosal graft, the graft is taken from the buccal mucosa for this grade 3 contracted socket with symblepharon, and later on this fornix deepening sutures were also given to take the support from the intraorbital loop to make it more deeper. And this lady has an exposed hydroxyapatite orbital implant, and she has undergone dermis fat graft but it was rejected because she had copious discharge during the due to that, and but she was unable to go the re-DFG. We were able to force the explant from the socket, and lateral the customized prosthesis was provided. So many a time you work, but there is a unsatisfied patients in a young 22-year-old girl which come for the prosthesis, but once made, she was not satisfied with because of the higher expectation. You see the results here in this area. So it is very important to promise less and deliver more in such cases. And also have the girl teenagers are very difficult to get satisfied than the boy teenagers. And but at the same time, you may get the satisfied patients where after the prosthesis, when it is made to us, it can be a better scleral show in this case, but still it's acceptable to the patient. So this patient, where we always say this patient has come to us for the orbital implant in
You just finish this slide.
Okay. Has come in 2017 for the orbital implant, and we have counseled to accept the prosthetic contact lens for 3 years over his physical eye, and it was cosmetically acceptable at that time. Later on, we have provided customized prosthetic cell for the over the prosthetic eyeball, and we are planning, because it's quite natural looking at this moment. We have a plan, once it become more physical, we can have explant it and then provide the another orbital implant. So to conclude, can I conclude, sir?
Yeah, just conclude. Yeah.
Yes. So take home message is contracted socket needs a special and meticulous attention. It raises the morale of the person. Correct assessment and meticulous step planning with informed patient is key to success, and custom-made processes adds acceptability and better cosmesis. Our publication is there on that.
Thank you, Dr. Ajit. I think that was a nice presentation of different kinds of grafts used. In the patient who had the failed DFG, dermis fat graft, what was actually done? I couldn't.
So the graft was taken from the glute area.
No, the failed DFG. So
Yes.
the patient came to you with the failure of DFG. Was a repeat DFG done for the patient, or?
So we have offered them the repeat DFG, but patient has rejected that. I want to get rid of this hydroxyplant because he was suffering since last 7 years. So at this she was in a distress.
Right.
See this, he was not even, we have given 2 to 3 times to think over and that one.
Yes.
But she says that just take it out.
So you removed the graft,
So
but how did you cover that area?
No, I have removed the implant basically,
Yeah.
and that socket was good. Basically, the conjunctival furnaces are good.
Okay.
So we have provided the prosthesis, which has a high toricity, you can say, and to have a good acceptance.
Sure, sure. So you did not do another volume replacement, or you did not need any surface area expansion? Okay.
Definitely not required,
Not
especially.
required. Fine, fine. Okay. Right. Any other questions, Dr. Pammi?
As a oculoplasty person, and the day just 6 on, I presented on contacted socket. So that's good that you manage the patient, but what I found is that when you analyze the evolution of the contacted socket, there's a two thing that is there: the surface and the volume.
Yes.
You can't correct just surface and give it prosthesis. You have to correct the volume simultaneously. And the first thing is, like, contacted socket is not the absence of eyeball. It is like an ophthalmos. If eyeball is not there, it's an ophthalmos. It could be the clinical ophthalmos. So contacted socket is something like when you have this, like, eyeball can be just a small micro-ophthalmos along with still the contacted fornices.
So it's an absence of functional eyeball.
Yeah, so that is an ophthalmic socket.
Yes.
So what I like, you have done the bill as a the surface part, but the simultaneously, like sir asked, that in that case, especially I want to answer, if DFS is fail, so there was one patient that I presented that day. It was a grade 4 contracture, and the patient doesn't have the surface, doesn't have the volume. So there was two option of going that. You can first correct the DFG. DFG will give you the volume also and the surface, followed by the MMG to
Yes.
create more surface. But that patient actually wanted less morbidity, because DFG and MMG is like taking the graft from the two area. One is oral mucosa and one is gluteal. So what I did is, there's I put implant for the volume correction. It's a very small eye, severe thysical eye. I done inoculation. I put implant. First I corrected the volume, and then for the surface contraction I put on, I did AMG.
Yes.
And so just my message is that evaluate both part and do correction for the both part. So then your patient will be happy. Like the young girl you have shown. So even see, if you will assess the volume, the superior sulcus deformity, that actually give the idea how much the volume is there.
Yes. Yes.
So if you will evaluate well and do this step by steps, this all socket patient can be make happy.
Yes.
So my message is just go like step by step and do. Otherwise the surface part is done well.
Definitely.
Yeah, thank you.
So we have some certain experience in few cases I was unable to show.
Sure,
It's
sure.
where we think of that we can that patient will require a surgery, but only the customized prosthesis, the cell, has given such a result that the prosthesis rotation has gone out and the toricity has just little so was better. So
Absolutely. There is absolutely a huge area, and
yes,
you touched upon some
so
of the
that's
areas
yes.
in a very nice way. Thank you, Dr. Ajit.